Hello, hello. Okay, we are being recorded. Hello, everyone. Happy Monday. I'll give you all a minute to get connected. See lots of people still connecting to audio. Good to see all of your faces. My name is Anissa Mitchell. I'm with PMD Alliance. I'm very excited for our Lunch with Docs today. We're going to be discussing mood and emotionality in Parkinson's. Before we get started, I just want to do the typical housekeeping things. Number one is to hover over at the bottom of your screen, open up that chat box of yours and give us a shout out. Let us know where you're joining us from. We love to see where everybody is coming from. And that is where you're going to put your questions. So we're going to be doing questions towards the end of the talk today. Also, you can see that we have live transcription up. You can keep that up if you like it. You can hover over it and you can move it around your screen. But if that is distracting to you, if you click over where it says live transcription, if you click on that, you have the option to hide the subtitles. So you can hide those and they'll go away. If you decide you want them back, you can go back there and re-establish them. It's lovely to see people from Texas, from California, North Carolina, even Canada. Great to see everybody. So with us today is Dr. Mindy Bixby. She is a neurologist and movement disorder specialist with us from Scripps Clinic in La Jolla, California. You may have seen her on some of our other programs. She is one of our buddies and partners. She has completed a residency in neurology, her fellowship in neurorehabilitation, and her fellowship in movement disorders, all at Georgetown University in DC, and now she's in California, and we are so lucky to have her with us today as she's going to be diving into something that I think a lot of us are very interested in, and that is the mood and the mechanisms of mood in Parkinson's. So I know she's got a ton of great information to impart to you, so I'm going to pass this off and welcome Dr. Bixby.
Hey everyone, I'm so happy to be here today, having lunch with the docs today. So I'm excited to talk to you about mood and also just give you a little bit more insight about everything that you may be experiencing, or maybe you just have some questions about. So let's get started. I actually have a PowerPoint for you. And again, we're going to try to do our best to make sure it's not too long, so we have an opportunity to answer questions if you have them after the talk. So let's get started. Give me just a moment, please. Okay, I think we're up. So today we're going to talk about mood and you. So let's do this. So the first part of it is talking about the talk overview. So we have several things to cover, actually lots of things to cover today, and we'll do our best to get through everything. But we'll be talking about the definition of mood, what things you may be experiencing, from everything from depression to apathy to anademia to happiness. We'll talk about the neuroscience of mood, exploration of mood and emotions, and how would you explore if you are having some of these symptoms, and where would you put it and what you could do for it. And so ultimately treatments, and also always figuring out how to do some natural stuff for us to keep our lives in a good place every single day. So let's get started. So let's first talk about definition of happiness. What is that? It's a mental state of well-being characterized by positive moods, that you can see all these people hanging out with each other. That's actually really a great way to have happiness, is have each other as a social network and feel just contentment and good fortune. The next is the definition of anxiety. I mean, am I anxious? The question is, I don't know, so let's see what that means. And so some people have, they have an external danger that they think something's going to happen to them, and that's anxiety. Let's say that somebody's in front of a bear. Yeah, I can imagine all of us would be a little sweaty and worried about that. And so that's one part of anxiety. But sometimes you don't have any external cues at all, or maybe things that maybe may not make other people anxious may make you anxious. And so, as that said, some people have anxiousness with Parkinson's disease, and you may notice that some of your symptoms get a little bit worse when you have that, or if you're under stress, for many reasons, whether it be an external thing that something's happening to you, or you haven't slept very well, or all the things that can create anxiety. And ultimately, sometimes you can see it in your Parkinson's symptoms and signs, whether you have more tremor or stiffness or slowness, or you feel more fatigued. And we'll talk a little bit more about that in a little bit. So other things, again, we just talked a little bit more about this. It's a very busy slide, apologize for it, but let's pick some things out. So some people may have this shortness of breath, not being able to take a deep breath. And is this anxiety, or is this something that has to do with your lungs? We're not sure, but we can kind of dive in a little bit deeper by understanding, maybe doing a diary of when this happens, and if there's anything that's maybe externally working on you, or if medications are changing, or you're wearing off, or you're just coming on your medications for Parkinson's or other things. And that kind of helps the physician and you to see if it's actually medication induced, or is it actually that you're wearing off from the disease, or it just has to be something that's external. And so these are the things that we tend to talk about in the clinic, to say, hey, let's see what's going on. Are you really fatigued, and why is that? Or you're avoiding of going out and hanging out with your friends anymore, and is that anxiousness, or is that just simply something that you just have another thing, which we'll talk about next. And so let's talk a little bit more about depression. So some people have depression that they had before they ever had Parkinson's disease, or you have it from, oh, I found out I have this and now I'm kind of sad. But sometimes you dive a little bit deeper, and we'll talk a little bit more about the mechanism of depression with Parkinson's. But some people may have some of these symptoms, as you can see, like depressed mood, or not having that much interest in things that you used to like, and you just you're sad about it, or you're changing in sleep, or weight loss, or weight gain. So those are some of the signs of depression that we always want to look at. And there is actually a wonderful scale that I use on a regular basis to just kind of dive a little bit deeper. I usually have a questionnaire before you come and see me, so I can actually make sure that I address that with you in regard to any type of emotions you may be experiencing that is new for you. Types of depression, it could be anything like we talked about. It could be an instance or something that happened, like for instance, a loved one passed away, or you had a breakup, or something else is happening. And so that's a situational depression that people tend to go through the stages and then ultimately come out not needing to be treated on a regular basis. And some people have adjustment disorder and some of these other things that may be not you, but hey, if you're in Seattle, for instance, which I've heard that it's not as non-sunny as it should be, but if you're having difficulty because you don't have a whole lot of sun, and you can have seasonal affective disorder, where people actually just need a light box to have the light hit them so they get a little bit more of that UV light that keeps them happy. So there's all these things we need to kind of talk about, so you can understand that there may be something that is fixable just by changing your situation. So the next thing I really want to talk about is some people come in and they say, you know, he doesn't like to do things like he used to do. He used to love to go golfing and play with the grandkids and do these things. He just doesn't like it or care anymore. And that's sometimes can be called apathy, because you don't have as much joy as you used to have with the things you used to do, or you just don't have any thoughts. I mean, you don't have enthusiasm like you used to. And so your affect may change a little bit, and people around you may think that you're depressed, but you're not. You know, you don't have a feeling of doom or sadness, but you are not doing the same things you used to do. And your personality may have changed a bit. And so we want to make sure it's not apathy compared to depression. And then sometimes those get intertwined, and that's possible, but we like to really dive in to say, hey, are you apathetic? I mean, maybe that's what it is. You're not like really sad about it, but it may be the fact that apathy is happening. And that's actually extremely common with Parkinson's disease, more actually so than actually depression. So it's good to actually understand a little bit more of the definition, but also understand if it's maybe a combination of both. And so we have to decide, so we make sure we treat you right. The next thing is anademia. Again, a lot of different ways of saying that, but what is that? And so some people can have a combination of this with the other things we talked about, depression and apathy, but sometimes it's just you don't have the pleasure in anything, and you just don't have a happiness. So hedonistic is a part of that word. And when people have like want things and it makes them really, really joyful, but maybe overly joyful for certain things, this is something that's A, which ultimately says you don't have that pleasure that you're experiencing. Nothing makes you happy no matter what you do. And that's a little bit different. So let's talk about the brain areas of those three things. And so if you can see on this screen, which I really like this slide because it gives you an opportunity to understand a little bit more of what's happening inside the brain in regard to anademia, apathy, and depression. And as you can see, it's different areas that are actually stimulated when you have these things, and other things that are not stimulated. And so if you look at the really, really bright color yellow, that's the main place where those people are experiencing things. Like, for instance, depression. See how it's a weird space? It's literally more in the deeper areas, which is really close to the hippocampus, actually, which we'll talk a little bit more about in a little bit. But understanding this slide a little bit more in regard to just understanding that it's different areas. And yes, all of them can be lit up, but most of the time, actually, it's one or the other. And that's why we have to kind of dive deeper into in understanding emotion, so that we can help you walk through this earth and hopefully get that happiness back in. So ultimately, the next thing I think is really, really important, which a lot of people don't understand or know, is there's something called pseudobulbar affect. Pseudobulbar affect means, if you just use the word pseudo, meaning it's not actually the way you're feeling, you're just showing that emotion. So let me give you an example. Let's say that you watch a Hallmark commercial, and you've watched many of them, and they make you a little sentimental, but you don't cry over it. But then you start crying. You can't stop yourself. It's like, I don't know what's wrong with me. I'm not sad, but my emotions are I'm showing you that I'm crying, but I don't feel sad, or I may feel a little sad, but nothing like to the extent of what I'm showing you. Or some people, which is a little bit less common in Parkinson's disease, is that they laugh in an inappropriate way. Let's say that they're in a funeral and they just start laughing, and they don't want to laugh, but that's just how it's like incongruent between how you feel and what you show. And so it's really important to actually tease this out and see if this is really what's happening, because people, especially with crying, automatically think you're sad, and it may not be the right actual diagnosis, and it's treated different completely. Interesting enough, pseudobulbar affect, again, like we've shown, we can see it in stroke and multiple sclerosis and brain injury, which I do a lot of, and then in dementia or cognitive decline, and also Parkinson's disease. If you need to have this treated, and this is what you're experiencing, you're like, hey, that is me, then you may be treated with cough syrup, not the actual cough syrup that you will drink, but in this medication called Nuedexta, that has the main ingredient is cough syrup, dextromethorphan, which again is completely different than giving you an antidepressant. So again, always important to know these things. This is so much more prevalent than the general population. If you don't understand it, you don't ask. And so they automatically think this. And so again, diving a little bit deeper, important to understand what's really happening with your mood. So again,
Dr. Bixby, I'm sorry, I just wanted to ask, so a person doesn't necessarily have to be experiencing depression to have pseudobulbar affect. Is this correct?
Yes, that's actually true. I mean, this is a perfect caveat to this slide, because people can feel a little bit sad, like they're again watching the Hallmark commercial, or missing their loved one when they got the phone, and then they go, gosh, I really miss them, and that's like seconds. But you cry like it's the worst thing that could ever have happened to you. And so understanding stimulus and affect and how their behaviors don't change, it's just that moment, it just hits you like that, is a really important thing to look at. And so that's why these questions are always answered as part of the depression workup. When I see people, is like, wait, maybe it's something different. And so it's really good to know and understand this. And some people may have never heard of it before. The next thing is understanding mood. Again, we've already talked about this slide in regard to understanding that there's different areas of the brain that actually get highlighted when you're happy compared to when you're sad. And they also actually looked deeper and looked at content and amusement and surprise and fear and anger and being sad or just being neutral. And they looked at different types of movies and showed different pictures on the screen and what highlighted in the brain when you had these things. And it was interesting because, as you can see, it's all different areas of the brain. But if you kind of understand where they are, you can kind of dive a little bit deeper in understanding why we'd have certain things with Parkinson's disease when you have a dopamine deficiency compared to other things with maybe all over the brain. Like, again, I have people that have multiple sclerosis that have really different emotions compared to if they have little lesions in the areas of the brain that we see. But I just want you to be aware that there's all these different places that you can look and understand why you would have certain things when you experience life and emotion. So a little bit deeper in regard to the limbic system, just so you can understand a little bit more about the anatomy of mood. And so if you can see this, so you see the little eyes, and if you go take your eyes and you imagine going back in space in the 3D opportunity, there's these wonderful things that look almost like a half C, which is called the limbic system. And right at the edge of that is where your basal ganglia hang out, which again is where your Parkinson's starts or is originating in regard to how much dopamine is in that area. And so if you understand that complex of understanding, that's what we need to make sure we focus on a little bit more today, is the neurotransmitters, the deeper portions of what makes mood. Okay, so let's look a little bit deeper. And again, I think this is a similar slide. The biggest, most important thing is there's 3 locations that they really look at for mood changes. And one of them, amygdala, which is like, if you have a lesion in that area, you just lose fear. You don't have any more fear. And so they kind of do a lot of more robust, interesting things where they normally wouldn't do. And again, it could cause emotional changes in memory. Hippocampus, which you may have heard of, is the short-term memory ability to actually lay down new memories. And so if that is lost, you can actually have an inability to actually lay down new memories. And then Parkinson's disease, which is where in the substantia nigra, which is a deep area of the brain, is where your dopamine is produced mostly. It's all over the brain, which we'll see at some point, but ultimately that's the biggest location of what we see as time goes by when you have Parkinson's. I think I may skip this because I don't have a whole lot of time, but this is just a lovely story about understanding the brain and the anatomy. And HM basically lost his memories because he had a lesion that he wanted to take out of a little bit of area of the brain so that he wouldn't have seizures. And they found the reason where the areas of the memory and also the mood happen. And it was a famous case as we dive a little bit deeper into understanding the brain. A little bit of a grainy slide, and I apologize, but we're going to talk a little bit more about anxiety in Parkinson's, which is quite common. About 30 to 40% of people that have Parkinson's will have an anxiety episode or anxiety on a regular basis, or maybe even a panic attack in time. But not all people have that, but I know that it's important to address it today so you can kind of understand it a little bit more. And so anxiety in Parkinson's usually occurs when you have a dopamine deficiency, because dopamine is also stimulating norepinephrine and serotonin. Norepinephrine and serotonin are really important to have for mood stabilization, whether it be depression or anxiety or some of the other things we talked about today. There's several ways to have a therapeutic strategy to help you with these emotions. Sometimes it's medications. Sometimes it's a non-pharmacological approach, whether it be like therapy, which I think is awesome. I think you need a therapist. You need a therapist. It's wonderful to have that opportunity to be able to talk to somebody that's not in your family that can help you through some things that may be happening to you. I'm a huge fan of that. I know mental health is sometimes a little bit harder to have access to, but I think it's really, really important for us to try and make sure you have somebody that you can talk to if you need to. Other things are TMS and DBS, which are ultimately still in the research phase of this. And then again, meditation and yoga, and we'll talk a little bit more about foods today as well. And so again, more anatomy, we won't go any further with this one. Neurotransmitters. So we just talked about that again. As you can see on the right side of the screen, those are all the neurotransmitters that are basically working together in concert with each other for you to be you. And so neurotransmitters are really important to have signals to understand our environment and also be able to take in information and be able to process it and be able to communicate and feel basically human. And so the idea is that if you have a low amount of it or too much of it, you can create different things. For instance, some people have a weight loss or weight gain. It's neurotransmitters. So ultimately, some people use foods for pleasure. And so you may eat more of that when you're depressed, or you eat more when you're anxious, or the total opposite, where you don't have those neurotransmitters kicking in. And so you don't have any appetite and you lose weight and all those things. So I want to make sure we talk about that as well, because we want to look at the environment. How's your body doing? And sometimes that will give us a good cue of what we should do moving forward to help you. And so ultimately, these are very important. So let's dive a little bit deeper to the ones that I think that are really important for mood. And so serotonin, norepinephrine, and dopamine. And as you can see, they all work in concert with each other. And so if you're low on serotonin or you're low on norepinephrine, you may be low on dopamine and vice versa. We do know that dopamine is one of your precursors to the other two. And so we want to make sure we do the right thing to modulate these neurotransmitters so you always feel good. And as you can see, if you put them all together, the mood and cognitive function is really important to look at. But this is something where if we can modulate, make sure you have all the right tools to move forward, we want to try. And that's why if you have a dopamine deficiency, you may be experiencing some things because of this reason. Let me give you the next slide. So let's talk a little bit about serotonin. So serotonin, I'm sure you've heard of something like Prozac and Zoloft. That is a SSRI. That's a serotonin reuptake inhibitors. Those actually keep your serotonin happy. So you keep your happiness going. And so if you're low on that, you may actually experience depression or apathy or other things. And so it also regulates sexual desire and your GI motility. Some people have really bad migraines because their serotonin is low. And so understanding serotonin and what it does for you is not just one thing, it's just a lot of different things. And so if you're low on it, you may be experiencing some of these things. And we know now that it's found in the gut and also in the brain. So I'm a big fan of understanding the brain-gut axis and how important they relate and talk to each other all the time. When the gut has its own brain, basically, it's called the autonomic nervous system. And so it's important to understand an enteric nervous system. And so those things work in concert with each other. So if you're low, we need to talk a little bit more about that because we can pump it up in other ways. So let's try. So how do we boost it in a natural way? So as you can see on there, over there, you see walnuts. I love talking about walnuts because walnuts look like brains, right? And so if you have the walnuts, they actually can help you pump up that serotonin. And there's other ways, actually hydration, and water. Smiling releases hormones. Did you know that? See all of us smiling right now? It makes you feel good. And there's actually amazing studies about serotonin release. Even smiling when you're not having anybody around you, it changes the way you feel, and it's actually allowing you to have that boost of serotonin. And so it's incredible. I actually run in the morning around 4:30 in the morning, and I smile the whole time because that was one of the clinical trials of talking about what you can do to actually, and then if someone's walking by, they're making them so happy because you're smiling, because our facial expressions changes a lot in the chemistry and the circuitry of our brains. And so smile as much as you can if you can. Leafy greens, again, everything that's nice and healthy there. I'm a big fan of eating the rainbow, and that's some of the things that we can experience when we have a need for serotonin. Other things, again, this is some other opportunities. So the whole idea is actually creating serotonin. So tryptophan is one of the things that actually gives you an opportunity to have more serotonin, which ultimately can help you with your mood. And some of the things here, again, depending on if you're vegetarian, vegan, there's all aspects and opportunities for you to actually increase your serotonin. Again, these slides will be available later. So if you would like to look through them later, please don't hesitate. And so managing mood disorders. So depression, again, if you can pump yourself up with exercise and smiling while you're running and walking and things like that, amazing, very wonderful. And again, sometimes you may need a little bit more help than that. And if that's the case, then sometimes we can give you a medication that can improve your mood. And there are certain ones that actually have been shown to be helpful for Parkinson's patients compared to the general population, which also help with the general population, but some of them have been used or tried and true with Parkinson's disease and helping you kind of pump up the serotonin. But this is just a slide showing you basically what happens. And again, giving you a little bit more serotonin may help you with your mood is basically what it's saying. These are some that have been shown to actually be helpful with Parkinson's disease: citalopram, escitalopram, fluoxetine, paroxetine, sertraline, and Vibrad, which again can help you with depression, eating disorders, obsessive compulsive, apathy, migraine. Interesting enough, there's a lot of things. And so these are some of them that have been shown to be very clean in regard to hitting one receptor only. So the side effect profile is much less than some other ones that you may have experienced in the past. but it really does help you kind of keep that serotonin available to you so you can use it throughout the day and you're not lacking in it. So that's what this does. This type of treatment would do. And so again, I'm all about food. I'm all about tips for helping you with mental health. And so you are what you eat. And so if you're eating a lot of processed foods and not drinking enough water, you're not going to feel as good as if you eat some things that are good from the earth that haven't been processed, and your body can have an opportunity to use all those nutrients for the good. It's definitely worthy. And so again, let's talk about dopamine. Let's dive in, and please forgive me if I'm talking too fast. I'll slow it down a little bit. I just want to make sure you get it all in, and then we can have questions afterwards. And so dopamine is amazing. It does a lot of things. And so I want to keep you pumped up and happy in regard to having as much dopamine that you need to keep you in a good place. And so why is it that mood changes happen with Parkinson's disease? Let's talk. So dopamine is a pleasure and reward neurotransmitter. I have had people that come in with their "I got my dopamine" t-shirts, because it's truly, if your dopamine's up in a good place, you're going to feel quite good. And so again, the precursors are norepinephrine and epinephrine, interesting enough. And so norepinephrine is a mood stabilizer. So if you're lacking in that, you're not going to have the dopamine that you need, and vice versa. And so low levels have been associated, again, like we know, with Parkinson's disease and ADHD, which is a hyperactivity disorder, depression, addictions, and introversion. And then high levels, again, too high, can cause mania and psychosis. So we also need to talk about that. If you're overstimulating yourself, you may feel manic, like you're overthinking things. You need to, overthink, or hypersexuality or hyper eating and things like that. So we want to make sure it's just in that right balance for your brain and your body. And again, everything that we do, that we're talking about today and every day when it comes to Parkinson's, is that you are an individual. Every single person will be treated differently in regard to Parkinson's disease and what you're experiencing. So that's why we have to make sure we can educate you the most we can so we can get the best benefit for you. So here's some great tyrosine things that will give you a little bit more more dopamine. And so all these things can actually increase your tyrosine, which basically is a precursor for dopamine replacement. So some people are ultimately on this type of diet that actually is a Parkinson's diet that gets you to a place that you may be able to have a little bit more tyrosine, which ultimately can allow you to have more dopamine production in the brain. And so what if you need help and more help? And most people with Parkinson's need some type of medication that will allow you to actually have more dopamine in your system that is actually really, really efficient, so that you feel better as time goes by. Some people choose to do more of the natural products of dopamine replacement. And again, there's nothing wrong with that. I think that's wonderful. Exercise is one of my biggest dopamine producers. That is not medication. But if and when you're ready and you need medication to actually help your symptoms improve and your mood improve, that sometimes dopamine replacement is the answer. And so there's some answers here in regard to what would give you more dopamine. Carbidopa, levodopa, Sinemet is one of the #1 gold standards for patients that have dopamine deficiency, because it's the most efficient to give it to you at this point today on August 2nd, 2021. This is the things that we have to actually help with Parkinson's symptoms and signs. Dopamine agonist basically means a lookalike dopamine molecule that allows you to actually have your body and your brain believe you have it. And so those are some things like ropinirole or Mirapex or pramipexole, Nupropatch. Those are some examples. Monoamine oxidase and COMT inhibitors are things that block your naturally occurring, monoamine oxidase inhibitors block your naturally occurring breakdown of dopamine, so it keeps it there longer for you. It's also been shown to really help with mood in patients that have mood changes without Parkinson's and with Parkinson's. It's actually quite good and used before knowing that it would be helpful for Parkinson's patients. It's been used for many, many, many years before that for depression and mood changes. So it's nice because it can do two things for you. Again, mostly used with Parkinson's and restless leg syndrome. Again, dopamine deficiency has, restless leg is one of the, dopamine deficiency is one of the reasons for restless leg, just so you're aware of it. And again, like we talked about, the psychiatrists sometimes use this as a depression management tool. Effects of chronic stress on your brain. All of us know that if you've had a hard day, you're fatigued, you're tired, You're trying to get through life. And if the chronic stress is all the time, it can create an inflammatory response inside the whole body. And we're looking at this so much more today than we did 10, 15 years ago of what stress can do to you. I mean, whether it be 32 hours working as a resident in a hospital all by yourself with 4 beepers, that's chronic stress, or something where you're having a hard time with life and things are happening to you. Whether it be anything from military service to things that actually would create possibility having some things in exposure that would create chronic stress. And so we really want to make sure that we're aware of it so that we can help you and you can help yourself, because we have to find ways to relieve stress the best we can, whether that just being walking around running or taking care of yourself in regard to resting and having siestas and being around friends and ultimately exercising and all the things that actually can create a decreased stress, increase happiness. And that's what this model is basically showing. Next slide, very important. How can you decrease stress outside the box? Again, we just talked about most of these things, but it's important to understand that, I mean, I write my journal every single morning and I have some of the most amazing quotes in the world from my patients because they say something or they do something like, this is a perfect quote in regard to understanding, and it allows us to build something and remember our day and kind of also let things go if we need to by writing things down. I think it's really, really, really effective. Other things like cognitive behavioral therapy, I'm a huge fan of that, like we talked about before, is kind of thinking about maybe having somebody where you can just like go, okay, these are the things that are bothering me, and not have all the personal aspects of it when you tell your spouse. Again, you should be talking to your spouse and your family about this, but sometimes it's nice to have somebody that has not a buy-in to your life and allow you to actually seek health without having anything other than having a very objective help therapy. So that's something I love to talk about in regard to music. Hey, put on your favorite song and do a little bit of a boogie. That's what me and my daughter do. And it sure has changed my day. And so we try to dance every single day, either in the morning or at night. And we'll talk a little bit more about the happiness jar next. So cognitive behavioral therapy, again, increase awareness, understanding, and sometimes you may not know that there's something that's a little bit different of what you do or how you think or get yourself out of that thought that keeps on coming. And how do you get out of that? Is there a breathing exercise? Is there a way to actually think about other things? Or just basically have your voice heard is sometimes all you need to actually feel better. So that's something that I'm a huge fan of. We talk a little bit more about anti-anxiety drugs. There are things out there. If you have something where you cannot control it just because you're feeling really anxious and you're not able to get through your life, there's ways to actually help you with that. And it's important for you to understand them and know them, that they're out there. And these are some options for you. And again, talk to your doctor, if you're having some time, and please know that, and that's your private sanctuary with your doctor. And that's how you should feel when you're talking to them. So if there's something that's really bothering you, please make sure you address it, because there's so many wonderful things you can do to help with anxiety. And these are some options, and there's other options like we talked naturally. Musophilia, huge, wonderful opportunity to understand that musophilia actually brings in your old memories and allows you to actually get to a place where it's been shown that it actually can lower your anxiety level and then pump up if you're a little depressed, if you just put on a song that you love and make it your routine, it makes a huge difference. And it's amazing what it can do to your brain. All those aspects that I showed you in the previous slides of how you can pump up the good happiness moments and kind of calm down the things that may be a little bit hard for you by just having some music in your life. Happiness jar. I'm a huge fan. I do this every year. I've been doing it for 10 years with my daughter and my family. And what is it? You basically put in some good things that happen throughout your day. Like I told you about the quotes I get from my wonderful patients, I put them in there. And at the end of the year, because boy, does time go by. I can't believe it's August right now. But what if you took a pause on New Year's Day and read about your life for that past year and allowed you to know, hey, there's some really amazing things that happened to me over the last 365 days. So I'm a huge fan of the happiness jar. We have given it out many, many times, and it's really wonderful to hear what has come of it with families and friends and even sport groups. We actually have sport groups that have the happiness jar, and we read through those too, and it's pretty fun. So that's one thought process as well. Engage in meditation and regular prayer has also been shown. There was an amazing study that came out that showed it lowered blood pressure and heart rate and increased energy and improved mood when you have an opportunity to have somebody and quiet your mind, whether it be through prayer or meditation, or a support group gives you an opportunity to just take a deep breath and you're with yourself. If you do that focus for 12 minutes, it's been shown to be very, very effective. And again, we have lots of time in our life, I know, and we have lots of moments and minutes in our days, but 12 minutes out of your life can change a lot about how you feel. Grateful, grateful, grateful. So we'll talk a little bit more about that too. So multiple therapy approach. It's not just one thing. You do not just one medication. It's not just one thing. We have to figure out what works for you. And so these are some things that have been shown to be extremely effective. As you can see, a depressed mood, brain on the left-hand side, and recovered. And they talked about this clinical trial where they did lifestyle changes, some therapy, and changed some things in regard to how their neurotransmitters were working, and it definitely changed their life. And so, a huge fan of considering doing an individual approach to helping you. A year of daily gratitude. So I started this probably, let's see, it's been 12 years now of talking about what am I grateful for? Am I grateful? And I say, and my daughter does it as well, 10 things we're grateful for right before we go to bed. And it just changes everything because it's been such a beautiful day. And there are things that we're grateful for that we can so simple. Some people just say, I'm grateful for my coffee right now. And because I have my coffee right now. I mean, what an incredible thing to say, hey, what a great life we live. We have so many beautiful things to be appreciative. And if we have in the forefront of our mind, other things tend to kind of fall back on the wayside. And we understand that this is our life. This is our one life to live. So why are we here? We're trying to make it happen every single day. And sometimes I just wake up and go, I woke up today. I'm grateful for that. And so that's a pretty awesome thing too. So we're striving for connection and courage and compassion every single day. And that's what this talk is about, is knowing what's happening, but also knowing that we're all here together and the connections here, and compassion, and understanding that we all, and you are all, having amazing amount of courage and moving through this life and being the heroes of your family. And so I want to make sure I open up with questions at this point so I can actually answer them. I think we're good at time. Are we okay, Anissa? Okay.
We absolutely are. And I know we'd like to dive into some of the things that you brought up. You had so much great information. I think we're going to have you come back and we'll do like sections of your talk, because you had such great information. One of the questions came in earlier is in regards to dopamine. So they wanted to know, how do we determine someone's level of dopamine? Can it be determined through blood work? Does it change throughout the day? And then I think that would be a great addition to going into, how does off affect mood? I know you touched it a little bit, but
for sure,
you address those together?
Sure. So the first question is, can you define it? Can you quantify it? How much dopamine you have throughout the day? Not yet. That's changing as time goes by. We have so many amazing things, even down to little wrist watches that you can watch how you're doing. Let me give you an example. If somebody's shaking like this when their medication's starting to go down, it will define that even before you actually see the tremor happen. And so those devices are happening sooner than later. And so that's a beautiful thing. But outside of that, there is something called a DAT scan, a dopamine active transport scan. It's a scan where they give you a tracer in just like a contrast, which goes to the basal ganglia and shows how much dopamine receptors you have left in the brain. Is that a normal thing that people do? No. Maybe about 5 to 10% of my patients get the DAT scan based on the fact that we're not really sure that they have a Parkinson's disease, and also the fact that their medications are not a robust response. Like, the whole goal is to get 50% improvement or more. And if you're not having that, or there's a question about some atypical symptoms I see or features, I get a DAT scan, a dopamine active transport scan, but that's not really normally done for a clinical evaluation of Parkinson's disease. The second question is, okay, and there's not a blood test yet for dopamine, just so you know, the levels, they vary, and ultimately how your body feels is going to tell us if you're deficient or you're lower than you should be. And again, some of you may have never experienced on-offs, but on is when you feel like your symptoms are better. and you feel like things are moving a little bit faster, and the tremor is a little bit better if you have tremor, and you're not as stiff. But when you start to wear down, meaning the medication that you're taking by mouth is lowering, that's an off period. So an off period means that you're starting to feel like the symptoms are coming back, and it's time to readdress them and give medication back in, or whatever you do to actually help your offs and ons. And so when you're off, yes, you can experience more anxiety and more depression. It's very clear because there's an area pathway that if it's not working very well, it can create a change in mood. And so there's an area of the brain, the basal ganglia, and there's a cortical limbic system. But basically, if it's not happy and saturated with dopamine, it can create anxiety and depression. That said, if your anxiety is more rearing its ugly head, meaning that you're having more symptoms based on the situation, or you're wearing off, you're going to have more tremor, more stiffness, more slowness. So they're like, okay, I've been under stress, so much stress over the last 2 weeks, but boy, my hand will not stop shaking. And I'm doing the exact same thing I always do, and I'm sleeping well and everything else, but I have a really bad, stressful life right now. That's going to show. You're going to see more tremor, more stiffness, more slowness, just simply because your body's trying to react and figure out what to do with that stress. And remember, dopamine helps serotonin and norepinephrine. And so they all have to be in a nice, even flow for you not to have the feeling of more of your symptoms. And so, yes, absolutely. I mean, it definitely can show if you're off with dopamine replacement therapy that you may have a little bit more stress and anxiety or depression.
Fantastic. And then someone wanted to know if restless leg syndrome is a precursor to Parkinson's.
So great question. So let me give you a little bit more about restless leg. So restless leg can be something you have or experience with Parkinson's disease. It can also be a very isolated, I have restless leg, and you only have restless leg for the rest of your life. And so that said, yes, a dopamine agonist or dopamine replacement therapy can help you with restless leg, but it doesn't mean it's a precursor to Parkinson's disease. Of course, I always look for it just to make sure I'm not missing anything. But you also can have restless leg when you have anemia, iron deficient anemia. And so that's one first thing I check is if you have a blood test, I check your iron studies. And if you're lower, we fix iron, restless leg goes away. But sometimes restless leg is something that's very isolated, and it's not necessarily a precursor to Parkinson's disease. No.
Great. And so you mentioned in one of your slides, it was listed OCD, so obsessive compulsive disorder.
Mm-hmm.
Is that something that you see as an issue in Parkinson's? And is there a correlation between that and the impulse control disorders that are caused by the dopamine agonist medications?
So yes, yes and yes. So OCD or obsessive compulsive disorder can be all by itself, isolated, okay? And you can have that before you ever get Parkinson's, and it can get worse with Parkinson's disease because modulating those neurotransmitters are a little bit harder, okay? But some people can have them from medication OCD. And so obsessiveness about, let me give you an example and define a little bit about what OCD is. You have an obsession, okay? Your hands are dirty. And you have to wash them to relieve that obsession. So your compulsion is washing your hands, washing your hands, washing your hands. And then at a certain degree of washing your hands, that obsession goes away and the compulsion will go away. And so sometimes you may see that with Parkinson's disease, where you're overthinking things or you're doing things like that, because neurotransmitters are all the same. It just depends on what levels you have to actually help you. And so dopamine agonists can create a little bit of the OCD. That's why I always, when I start that medication, I talk to the person, but also the person that's also part of their lives, say, hey, just kind of watch that, because again, it may not be very apparent to the person that's taking the medications.
In a follow-up to that, I just got a message with a question: is OCD seen more or impulse control disorder in those with Parkinson's?
So definitely impulse control more. Impulsive meaning anything from just hyperness. So let me give you an example. So some people actually come in to this Parkinson's disease and they gamble. They like to go to the casino and they like to have, they love that high. And again, it's a normal amount. Oh, okay, let's go do this. I won. This is awesome. Okay, walk away. When it comes to Parkinson's, sometimes you can have much more of that, whether it be medication induced or the disease itself. And so you have to kind of watch it. That's why I always ask about mental health prior to Parkinson's disease diagnosis, kind of so I can kind of get an idea of what we may be wanting to address earlier than later.
And the OCD is still the topic here. So this person just wrote in, should you try to work through the OCD or allow the person to go through it?
Great question. And so there's a lot of research on both. The idea is that it depends on how much insight that person has. And so I'll give you an example. I have patients that are just straight, not having any cognitive decline issues at all, and addressing that would allow them to understand that it's happening. A lot of times I actually ask permission. Would you be okay if your wife or your husband told you that that was happening? Because a lot of times they don't realize it's happening when we're in the office, like he's doing this or she's doing this over and over and over again. And I don't want to hurt their feelings, or I don't want to be nagging them, but what do I do? And it's situation specific. And so understanding that you have a marriage, whether it be your daughter, your son, your wife, your husband, your partner, whatever, the idea is that we need to communicate with that person and say, this is what I'm seeing. And they may say, no, it's not happening. And that's another thing where you have to figure out how to build a trust and a bond with each other, so you know what is the right thing and what the right steps to take. Because a lot of people, especially when it comes to OCD, and it's somebody's having a difficult time, and it just relieves them so much, but they're not doing it so much that it's creating, scars on their hands and things like that from washing hands. I'm just giving you that example. Then it's not a harm to themselves. Then there's sometimes it's actually so relieving that it may be something that you allow them to do. But that said, OCD is a very different chemical change in regard to understanding what direction. Is it impulse control, or is it OCD that was underlying and it didn't see it until Parkinson's happened and it became much more apparent? And so that's kind of where we have to walk through that walk together individually and see what we can do.
All right, I had a question earlier. This person said, having said imbalance of neurotransmitters, not only dopamine, but what is your comment on the combination therapy for the balance of dopamine, serotonin, and norepinephrine?
Okay, so you have to figure out where you are. And again, everybody's individual. So when you're dopamine deficient, you tend to have some serotonin and norepinephrine deficiency. It's just the way that the feedback loops happen. Some people more than others. And so defining that and understanding what is needed in regard to serotonin reuptake inhibitors or norepinephrine reuptake inhibitors and medications versus like, let's go exercise and let's get in a better quality and frame of mind. So usually when you actually replace the dopamine, the other ones follow suit. Sometimes your serotonin is still low and norepinephrine is still low, and then we consider actually pumping that up, whether it be through foods or medications. But it's hard to answer that question for every single brain, because as you can see, it's so individual. You don't want to do that. I don't feel comfortable about saying this is where everybody in this call should be on, because that's not fair to you. And so again, talk to your doctor. What are you experiencing? What you can do moving forward, and see if and sometimes it's trial and error. Okay, this is working great, but this is the problem I'm having now. And it helps because sometimes actually trying something will give us so much more insight about what you really need. And so, but you have to be willing to, I know, sometimes have a little bit of a trial and error and say, hey, this was very helpful for me, and I'm happy that I feel this way now. And so it's, again, we have to make sure we talk about it in an individual process instead of having a blanket statement. It's just not fair to you guys,
Absolutely. The next question kind of goes along with that then, because you mentioned, utilizing certain foods. So this person asked if you mentioned the Parkinson's diet. So they want to know, is there such a thing and where can we find it?
Okay, so I'm still working on it. And all my research is really big on foods and what you're doing for yourself. There was several nutrition, Parkinson's disease evaluations in regard to looking at all these different studies and doing a review on them. And what the majority of the review from my aspect of looking at all those is that what they really did talk about is processed foods are really hard on your gut, which ultimately is really hard on your brain. The second thing is that ultimately any type of cow products, whether it be meats or milks and things like that, have a much higher level of pro-inflammation, excuse me. And ultimately, they do believe Parkinson's has a degree of inflammatory response, whether it be genetic or coming from other different things, whether it be well water or you've been exposed to Agent Orange, all those things. And again, some people idiopathic, we don't know why it started in you. Is that if you can decrease the inflammation in your body the best you can, again, some inflammation is good because it protects us, but if it's really high, what can you do differently to help yourself? And so trying to look at the antioxidant diet, anti-inflammatory diets are quite effective, but those are the things that they said across the board, and all the articles, reviewing them all together, that's really what they're looking at. Fresh, healthy foods that your body can break down, water, small meals throughout the day, not big, huge meals, because ultimately make you very sedentary and tired. It's hard on you, especially if medications are not being metabolized because your gut's full of a lot of food. So small little meals throughout the day is much more effective for actually anybody, because your body's not always ruminating and fixing and breaking down those foods, because I want everything to work well for you. So those are the things that I have found at this point. We're getting there. I mean, again, we've changed everything from the Mediterranean diet to Atkins diets and all those things, and everybody's just different. But if they can find a way to decrease their amount of anything that's overly processed, anything that can sit in your cabinet for more than 2 weeks, it's probably not the best thing for you. You know what I mean? Because ultimately they have to have preservatives in that to actually create an opportunity for it to last longer. And again, I'm not overly, I mean, everything in moderation. You don't just go strict, because that you're not have a good quality of life, but it does help tremendously. Be thoughtful about what you put in your mouth, for sure.
So we talked about anxiety, and I know that runs the gamut from, mild stress. And this person said stress is their number one thing that seems to suck up all my carbidopa, especially if it's long term, such as being in a situation you can't walk away from. So as much as possible, they seek to avoid stress. And then we've mentioned a little bit about like panic attacks. So besides medication, are there any suggestions you give to your patients when they are struggling with social anxiety or having some panic attacks, so that maybe some things that they could try to do if they are in a situation they can't necessarily get out of?
Sure, absolutely. I mean, I'm not a psychiatrist, let me just tell you that, but I do actually treat a lot of people to make sure I get to the right place in regard to helping you when you're in situations and understanding a little bit more about why it's happening. That's our first dive in, is like, okay, what brings you to that space? Is it the way you're talking in self-talk? Is it a situation that makes that you're fearful for something that happened in the past? Is it more that you're wearing off of your medications and that's why you feel that social anxiety? And is it the right amount of medication for you? Eating up that dopamine because you're in a social situation that makes you uncomfortable? Is that's what's happening? So the most important thing first is to address understanding of why you're having it and what situations make you get to that place and what you can gain from that situation compared to what it detracts from you. And that will be the balance between understanding how we treat it. And so again, everything from breathing exercises to put your feet solid on the ground and saying, okay, I'm here. What do I do? And how can I actually make sure that I can be a part of this? Because I really want to be here. And so that's another thing, is like, why are you doing it? Is it because somebody else is telling you to go? Or is it that truly it's something that you're going to get some benefit from it? So those are the things you have to address. So it's almost like a diary, or like a PD diary that I do. Why is the situations changing in you, and why do you feel that way? And maybe we can dive deeper and help you. And it may be the fact that the serotonin is low, and we just kind of get you to the right level of serotonin, and it's not as hard on you. It's a hard question to answer if I don't know you, but that's kind of how I start my process of understanding of why you're having it, if that helps.
And I know that in terms of like dealing with and defining apathy versus anhedonia, that can be challenging, but I wonder if there's any like words of wisdom or suggestions you could maybe give the care partners out there and the caregivers that are trying to help their loved one do all the things that they need to do, but they're just not interested?
Yes. So the first question is asking why, and seeing what is it that's keeping them from wanting to do those things. And again, you may have walked this earth for 60 years and being around big groups has never been your favorite thing, and that's something that we need to talk about. But what if you've always loved doing certain things and you're changing, and you want to ask the right questions to your caregiver, your person, and it can be really revealing for you and for them, is that I don't understand, and then you get maybe a frustration or gosh, I don't understand, or you sad because they don't like to do the things they love to do. And it's just a change, it's a new normal. But does it have to be about a bad normal? No, it has to be like, okay, let's kind of work through this moment and say, okay, maybe I need to stop asking to go golfing because he doesn't like it anymore. And let's find something that he does love. And asking those questions are going to make all the difference in the world. It's like, hey, let's communicate. This is what I know now from this talk, that this is something that you may be experiencing. Is that something that you want to talk about? And sometimes they don't know themselves. That's something that is also important, is like, let's educate. Okay, this is something that's happening and I didn't even see it, and let's talk about it now. And now it's the box is open. We're having discussion now that we've never had before, because I don't want to hurt his or her feelings, or I don't want him to get angry. And so if we can have a nice, very safe environment, that helps tremendously, even as bringing it down, because sometimes patients feel that their care partner is asking those questions in front of them, like they're not involved. You may want to talk to the person before you bring it up to your doctor, because they may feel like they're not safe. And that's a really important thing, to always feel safe in the doctor's office and see how things are going. And so having that opportunity to have a voice, which again, you have to talk to your doctor to see if that's okay, whether it be your doctor or your husband's doctor or your wife's doctor, but knowing the steps to take to make sure that everybody feels respected and heard is everything. And so with all of us, we're humans, that's what we like to feel. I mean, if I'm feeling disrespectful, I want to walk away. If I feel like people are not listening and not feeling like and knowing and hearing me, that's much harder for me to continue on. And so being that person's advocate, but also, hey, you're a friend and you love each other. And so building a relationship and a communication before you walk into the room with the doc, so that there's ways, okay, hey, this is really happening to us, and want to know what we can do and what tools we can use. But again, situational, I know it's going to be different for every single person, but if you can know that these are the things that can maybe happening to the person, then you have a little bit more insight. You look at them and sometimes the facial expression is not the same as it used to be. And, oh, he doesn't care about me, or she doesn't care about me as much because she's not smiling at me on a regular basis. Well, there may be different cues to actually use, that the love is absolutely still there. It's just that the facial expression may not be absolutely the same. And so again, working with each other and saying, hey, how's it going? Is there something I can do differently? Or is there some way that I can help you? Or is there something wrong? And again, sometimes they're like, no, I'm fine. But what if you asked it differently? Now that this talk is very clear, that there's things that happen that may not be your mood congruent of how you feel in your face, maybe completely different, where you feel tons of love for the person that's sitting in front of you, but you're not expressing it the way they're used to. And so the communication has to be open at all times.
Well, this has been very amazing. You've got to have a lot of great information. We've had a lot of great questions. I think we could probably come back and dive deeper into some of these topics, because there's a lot. Yes. So I really, really appreciate you giving us such a rounded overview of a very enormous subject matter. So thank you, Dr. Bixby. We are out of time. If everybody would be willing to give their wave of gratitude, we thank you so much for being a part of this program. Thank you, Dr. Bixby, for your wealth of information. It's been fantastic. And we look forward to seeing everybody again very soon. Thanks so much for joining us.
Bye.
Bye.
Bye.